The National Institute for Communicable Diseases has dismissed social media posts claiming that typhoid cases have been caused by contaminated municipal water. The institute says this is false, adding that such posts cause unnecessary panic. It says there's no evidence that the bacteria causing the disease has been identified in municipal water sources in the country. The Department of Health has announced changes to the vaccination program. These include the reduction of time, that's the interval between the first and the second doses of Pfizer, from 42 days to now 21 days, effective from Wednesday. To speak to us about some of these adjustments, we're joined by Dr. Nicholas Crisp, the department's Deputy Director General. Dr. Crisp, good evening to you, and thank you for your time. Before we talk about what these changes are, let's maybe understand what has informed these changes.
Yeah, good evening, Kathy, and good evening to the viewers. So when we started off with Pfizer vaccinations, the interval was 21 days, but we had a serious vaccine constraint at that time, and there was evidence that widening that period between, which we call the interval, to 42 days, still gave a good immune response, so we did that. Now we don't have a vaccine constraint, and it's inconvenient for people to wait for 42 days. We also have vaccines which will expire if we don't use them. So it's to everybody's advantage that we reduce the interval and we allow people to come quicker for their second dose. You know, people you sort of forget about it and you postpone things if you wait too long. So that is what has informed that.
All right. And in terms of the kind of vaccines that people are getting, so it's no different to what those who were vaccinated before would have received.
Yeah, so let's try and explain it like this and say that a vaccine is an agent that you put into your body. It's a protein, or it stimulates the production of a protein in your body, depending on which vaccine it is. And then your body recognizes that protein as being very similar to that of the virus, and it makes antibodies and immunity to that protein, so that when your body finds or is exposed to the actual protein of the virus, it already has memory. The second thing that our immune systems do is they create a cellular immunity. So you'll hear people talk about the T cells or the killer T cells. Those are not just antibodies that coat the virus when they come in and prevent the infection, but they are cells that actually eat the virus and destroy it. So what we do know is that these vaccines, the same vaccines, not a different vaccine, the booster, it's just another dose given after a period of time that reminds your body to make immunity. And what seems to happen with a booster is that if you've had a primary vaccination schedule, your booster dose after a slightly longer period wakes up your cellular immunity very efficiently, so it allows you to generate antibodies and a good cell immunity against the virus when you finally get exposed to it. I know it's quite technical, but perhaps that's useful to try and explain it like that.
And let's talk then about the booster shots. So there was, again, a perceived waiting period after the initial 2 doses, especially if one was taking the Pfizer vaccine. What does the new legislation say when it comes to how soon one can get the booster shot after completing the initial round of vaccination?
Kathy, around the world, people use different schedules depending on whether they have vaccine or don't have vaccine and whether their communities are at risk or not. At the moment, we have a large proportion of our adult population who is at risk because our vaccination coverage is not nearly as high as we need it to be. So the sooner we can get larger number of people properly vaccinated, properly immune, the better. And by shortening the time period, because we do have vaccine available, we can do that. We've already paid for this vaccine. So the quicker we can make it available to people, the better. So what the scheduling has done differently is that for some months we've been getting advice on the mixing of vaccines. So people move around all over the world and they tend to get vaccinated in more than one country, those who are very mobile. And the evidence already started to show that it didn't really matter. As long as you are stimulated by the vaccines more than once, you do get an immune response. But the controlled studies have now shown us that not only is it safe, but you get a very good immune response if you have, after a Johnson & Johnson vaccine, which is, we call it an Ad26 vaccine, if you get that, either another Ad26 vaccination or an mRNA vaccine. And in our case, we use Pfizer, which is an mRNA vaccine. And we do know that after 2 doses of Pfizer vaccine, you can either get a 3rd dose of mRNA, Pfizer vaccine, or a Johnson & Johnson vaccine, and you still get a very good immune response. So that's why the mixing and matching has now been formally adopted, because we know it is both safe and effective. And we have programmed the system so that it allows for that mixing of those doses.
Dr. Crisp, you spoke about vaccines expiring. I know it may be difficult to tell because I'm assuming that they're all on different schedules and as far as expiry dates are concerned. But what's the big risk here in as far as making sure that these vaccines do not go to waste?
Yeah, so all vaccines expire, all medicines expire. And particularly with vaccines, which are what we call biologicals, their shelf life and their fridge life is very short. So the mRNA vaccines have a shorter expiry date, and they're the ones that are most at risk for us. We have just under 500,000 of those doses that will expire at the end of March. So we need to use them as quickly as possible. And then from April, May, and June, mostly in June and July, we have batches of vaccines which will begin to expire again. So we have around about 15 million doses of Pfizer vaccine, all of which will expire before December this year if we don't use it. So we would like to use that 15 million doses. And then we have Johnson & Johnson vaccine, more or less the same amount of vaccine available to us. But that is much more stable, and they do not begin to expire until next year. So some of the vaccine is at risk if we don't use it, and it would be a great shame to not use it, 1, because of its expense, and 2, because it can protect people even from severe illness and death if we can just get it used at this stage.
You've made the point that ultimately these are vaccines that government has spent money on. I think perhaps the track record of the vaccination campaigns over the last couple of months are a good indicator of whether or not, let's say, for the mRNA vaccines, the Pfizer vaccines that expire at the end of March, you would need at least 250 people to sign up for those vaccinations in order to ensure that they don't go to waste. I mean, are you confident that these are the kind of numbers that you might be able to reach?
Well, we need 250,000 people, and we were vaccinating at one stage 290,000 a day. So if we could see 250,000 in a week, then already we'd be able to use the vaccines. The problem is at the moment we're only seeing between around about 65 to 75,000 people coming for vaccinations. Not all of them are getting Pfizer vaccines because some of them are getting follow-on Johnson & Johnson. So the challenge for us is to get people who have never been vaccinated before to come for a Pfizer vaccination, to use Pfizer as the booster, either after Johnson & Johnson or after the primary schedules of Pfizer. And for those who have had one Pfizer, to give them an opportunity to come quickly for their second dose, since we know we get a very good immune response after even 21 days. So if we can shorten the inconvenience for people, shorten the time, there's no reason why the health system can't cope. We have the capacity to vaccinate 250,000 doses a day. So it's really a matter of encouraging people to come forward and not about our capabilities to use the vaccine.
In the absence of having those numbers, what then becomes of these vaccines? And I'm asking here from a context of perhaps the region as a whole, SADC, and even just the continent, which we know has been facing its own difficulties in terms of accessing vaccines. So, is the only option that it'll simply be thrown out?
So for short-term vaccines, we've been extremely critical of the first world who's been dumping short expiry date vaccines into countries that can't cope. And we would not want to do that and compromise other countries either. But for those that have got a longer expiry date, indeed, we are in discussions with various agencies to make that vaccine available. And it's a complicated process that works across the international space. There are international agencies like COVAX that we work closely with and have worked closely with, and the WHO, because they have access to all the countries around the world. So those discussions are ongoing, but for vaccines that have very short periods left, we need to use them, and we need to use as many as we possibly can to be responsible with. This is not government's money, it's taxpayers' money. So it's our money that we have invested, and as citizens, we should make use of the opportunities and get our vaccinations. It will keep us out of hospital, and it will keep some of us from dying.
So ultimately, Dr. Crisp, if I'm hearing you correctly, you're saying if these, just under 500,000 shots are not used by the end of March, specifically for the mRNA vaccines, that they will have to be disposed of?
That's correct.
How much do they cost?
Well, they cost about 350 Rand a dose, so that gives you an idea. Sorry, I haven't done the maths right now, but it's a lot of money.
Oh. All right, don't worry. I'll get crunching on my calculator as soon as I let you go. Dr. Nicholas Crisp, he is the Deputy Director General in the Department of Health.